Hi, how are you? My name's Alison Salmon, and I'm actually put together a 2-hour workshop that looks at the common back conditions that we face in the Pilates world. It doesn't necessarily need to be just the Pilates studio, of course, but other health professionals face as well. I'm trying to link this to the common presentations and obviously trying to make it as simple as possible for you guys to ensure that you're giving the best information to your clients, helping you feel confident with delivering exercise to people with back conditions, and also helping you feel confident in delivering that same information to your clients and helping them feel confident with doing the exercise themselves, maybe either with you or actually on their own, and that may happen as well. So basically what we're trying to do is integrate the Pilates method into these common back conditions. And there are many myths out there, there's lots and lots and lots of information, and sometimes it just becomes all a bit confusing, and as we all are, get really confused. As you know, many of you know that my background, I'm an osteopath, I'm a registered osteopath here in the UK. I've been studying Pilates for over 20 years, so I teach for Stock Pilates as a lead instructor trainer in the UK, but I'm also classically trained under New York Pilates Studio as well. And it's my interpretation of Pilates, of course, and that's what Pilates is. It's just interpretation, and it's a fabulous exercise method. And what we're trying to look at is maybe the anatomy to that Pilates method, but also how we can help people get through this pain when maybe they've hurt their back. Okay, so looking at the common pain presentations, and this is the sort of pain presentations that you may come across. Sometimes they are already going to be diagnosed, hopefully, by the time they get to your class or your studio. But sometimes you may find that actually they're not, and you could pick up on it. I'm not saying that this is giving you a skill to do diagnostic testing, but what it's doing, it's giving you an idea and an understanding of what may potentially be happening with that client, and maybe you can then refer them on to a physiotherapist or a fellow clinician or even their GP to get a referral. Okay, so it's just giving you that confidence. So the main common back presentations are in these areas, or these are the areas I believe in. And I've got a lovely spine here to show you. So what we've got is the pelvis, of course, and then the full spine. So what we have is the lumbar spine, which is 5 vertebrae, and then we've got the thoracic vertebrae, which is the 12 vertebrae there, and the neck is right at the end, the cervical spine. Oh, this one's a bit twisted up, and this has got 7 vertebrae. And again, of course, it all works completely as a unit. And what you know from your anatomy, hopefully, is that you've got vertebral bodies, and then you've got discs in between each of the spine, and they're obviously for shock absorbency and giving the spine its shape and its flexibility as well. What I really want to stipulate is actually movement is key with the spine. The more movement and mobility that you get through the spine, the more nutrition the body below is getting, because actually it provides its nutrition, or gets its nutrition from the vertebrae above. So the more articulation, the more movement through the spine in any injury is the best thing. Okay, so stasis is not good for the body, mobility is key for the body. So again, you're only as flexible as your spine, as they're saying. Yeah? So what we're actually looking at here is, firstly, is the lower back. So the lower back has those 5 vertebrae, and what you'll see is the 5th vertebrae is actually a little bit different. It's a little bit more of a wedge-shaped fracture. And actually the most common area to have disc degeneration and the likes is actually L4 and L5. So what they would normally call that is an L4, L5 presentation, or an L5, S1 presentation. And so what actually this happens here is because of that lordotic curve of the spine, maybe those vertebrae start to come forward a little bit, and then it actually creates maybe degeneration on the discs and the likes. Okay, sometimes people could maybe have where the facets are becoming a little bit closer together at the back here, maybe due to the degeneration of the disc, or maybe just due to the shape and the bad posture that they've created over their lifetime or over a few years. What you also find within the spine is these nerve bits. So what are nerve bits? I said it's got central nervous system running down the center here, but what you've actually got is peripheral nerves at each of the exits at the foramen on each level of the vertebrae as well. And these are really key to a lot of these common presentations. So what you're actually looking at is the lumbar is really mobile. And even when you're bending forwards and backwards, you can feel how mobile it is. What you'll actually notice is the neck is the same. A lot of people get a lot of neck injuries because they overuse their neck. But what actually the area that doesn't work so much or isn't quite so flexible is the thoracic spine, because you've got all these ribs there, and the ribs are actually restricting the movement. So what, again, you have a very mobile section, a hypermobile section, a very little movement area, which is a hypomobile section. And then what we've got here at the top is the hypermobile section. So you've got points in the spine that these hypermobile bits are meeting these points where it's not particularly flexible. So those common sites are C7-T1, T12-L1, and then L5-S1. So those are actually your weak points, actually, because those are the points that actually meet those different types of vertebrae as it changes, as the spine changes all the way through. So let's look at these common presentations here. And what I'm looking at is the lower back itself, whatever injury there is. There can be often a pain referral pattern with that. Sometimes they do, or sometimes they don't. Sometimes they might just have a central back pain and there's nothing else going on. But other times you might find that your client has pain into the legs. It might be just randomly on the thigh or the back of the leg or the calf or even into the big toe. You might find they might have some form of numbness. Again, it might not be the whole leg, but it just be certain sections of the leg. A friend of mine had her numbness at the lateral thigh there, and it was like the brachial saphenous nerve or something. So literally on that outer front thigh. What you'll also find is sometimes people don't have numbness, but they have pins and needles, or maybe a loss of sensation, not quite numb, but something not going right. And then, of course, some people might have a slight weakness as well. So any of these disturbances is where the actual nerve root is becoming disrupted, okay? So basically with numbness and pins and needles, what they suggest is there's actually a partial occlusion or an entrapment maybe on the nerve, whereas something when it's a pain referral, it's actually more likely to be more of a irritation of that nerve root. It could be because the surrounding muscle tissue is like really tight and it's irritating that nerve root. It could be the cells around the nerve system itself. So you've actually got these nerve cells called nociceptors, and sometimes they just get a little bit overexcited. Okay, so again, they may create pain in different areas, and it feels quite random. So a lot of people might say they haven't got back pain so much, but they've got this pain in their bum cheek. So some people might even call it, oh, I've got sciatic type pain, or I've got my piriformis is painful. So they've heard all these points and terms being thrown at them. Okay, so again, you've got with or without pain. It also could be with or without numbness or pins and needles. Now again, it could be presented at different stages in the legs that I've just hinted. So you could suggest that the legs are maybe pained in the anterior portion, the front part of the leg, or it could be the posterior portion, or actually it could be towards the side, so maybe where the adductors are, or even in the inside where the adductors are. You even have something called a C presentation, which is where someone does this sort of thing around the hip joint, and it's actually, that's an area that isn't necessarily from the hip joint itself. It tends to be coming from the back rather than the hip. Okay, so that's really your presentations, the most common presentations around lower back pain. So we're going to go into the conditions in a minute. All right, so then this takes us up to the next point, which is T12-L1. So this is this point that I've talked about, where a very immobile section is meeting a very mobile section. So again, if you look at the type of vertebrae as well, if you look at how the vertebrae of the thoracic spine is positioned, the spinous processes go down like this, whereas actually the lumbar spine is a little bit more squarer in its spinous processes, so it doesn't quite fit properly either. Now when you get this sort of mid-back pain, maybe it's because people are doing too much rotation, or they're sitting at a desk and rotating from one screen to the other, and they're finding that's the point they're rotating on, along with this very mobile section of the back, lower back, and then this not so mobile section of the thoracic spine. The thing is though, rotation actually comes more from the thoracic spine than the lumbar spine. If you look at how the structure of those facet joints are, you'll see the facet joints actually point backwards on the lumbar spine. Actually, the rotation at the lumbar spine is maybe 1, 2, maximum 3 degrees per vertebrae there. So you'll find that actually it's very limited. The lumbar spine is very good at flexion and extension, but not so good at rotation or side bend. Whereas actually the rotation is more likely to come from the neck. We know that the head moves quite a lot. Of course, you need to turn around from one side to the other. But of course, also, you've got the rotation coming from the thoracic spine there as well. So sometimes if there's an area of pain in this area and it's been over rotation, it's because someone's tried to over rotate the lumbar spine. They haven't rotated that well, so they've over rotated in the thoracic spine, but just at that point. They haven't done this even rotation through the spine. So even if we're linking it back to Pilates, when we're looking at the spine twist, for example, most people initially are very good at rotating on this one point. But what they should be looking at is lengthening the spine as they're doing that. So as they breathe in, maybe creating that length and rotation. So each of the individual vertebrae then are actually rotating evenly rather than just one vertebrae taking all the load and the rest of the vertebrae just staying quite static. So this again is a great way to think about teaching your clients when you're actually doing the exercise. You want even movement through each of the spines or each of the different vertebral bodies. You don't just want it from one area. And this is where someone may have flat areas or maybe areas that don't necessarily articulate. We are just encouraging articulation because movement is key. That's really all it is. All right, so then going from the mid-back now down to the up to the upper thoracic. So we're looking at the thoracic total. As I said, it's quite restricted because it's got the ribs. But the great thing about the thoracic spine, actually, it doesn't often have disc prolapses in this area because of that rib cage and that structure. Occasionally it does. That tends to be more through trauma, maybe injuries or an accident or something. But as a rule, there's not really that much disc degenerate or disc prolapses in that area. But what you will find is this area, people get that upper back pain, maybe from posture a lot of the time. So a lot of it could be overstretched muscles, tightness in the chest, they're stuck in that position, they create that kyphosis, maybe even they quite be flat, lower thoracic, kyphotic in the upper thoracic, and then they stick and poke their head forward as well. Probably like most of us are doing as we're sitting over maybe laptops and computers a little bit too much. Okay, so this area again needs to be mobile. So it's very good at sitting there in that flexed position, but actually we do need to articulate it. We need to ensure that there's some extension there, obviously side bend and rotation as well. What you might find in the upper back area, it tends to be very much mid-scapular range. Maybe it's because of that posture. Even the rib heads. Now the rib heads themselves, where the spinous process is, at the side here you've got the transverse process and then the rib comes through that. And actually this is what I mean by a rib head. Sometimes from bad posture or maybe they've done something, maybe over twisted, maybe did a bit of DIY or something, you can have a slight dislocation of this rib head here. And actually it causes pain, but it's very localized in its pain. It's really hard to actually get that right again, but it does take a little time, but movement again is the key. You could of course see an osteopath or a clinician to maybe adjust it if you really need that, but actually you can do similar things with exercise and maybe some of the equipment like the spine corrector or similar. Okay, so again, you're looking at the scapular position. The scapular position itself shouldn't really be winging. It shouldn't be anteriorly tipping. It should be gliding across that rib cage. And sometimes it doesn't do that in a lot of people. So again, we need to look at that shoulder stability generally. And again, what I do look at is when I'm looking at this thoracic region, I don't just look at the thoracic spine, I look at the scapula, I look at the rib heads, and I look at the positioning of the shoulder because it's all really very, very important. Okay. So finally for the spine then, you've got the cervical spine. So the cervical spine, including what they call the CDJ or the CTJ. So that's basically cervical dorsal junction or the cervical thoracic junction. Just depends on who's taught you actually. I had older people teach me, so it's very much an old term, an old osteopathic term. So what you've got here again is the neck. Now looking at the neck, you can see the vertebrae are much smaller in this area than they are in that lower lumbar. It's smaller, and of course the discs are much smaller as well. What you'll also notice, there's a couple of differences here. One, when you look at the articular pyramids or the transverse processes, they actually have their own foramen. And what you'll notice here is that artery, that red artery goes all the way through there as well as the nerves coming out of the individual segments out the lateral foramen there. So there's a lot going on in the neck, okay? So what you'll also find with the neck, you can have neck pain, whether that be a disc prolapse or whether that be a facet joint or something similar, But what you could also have is not just localized neck pain, but that could refer. So it could refer into the arms or the shoulders. So if we think about the segments, then we will look at the segments at some stage as well. So everything from sort of C4 downwards will refer into the shoulders, maybe into the biceps, triceps, and all the way down into the fingers. So if it's starting to provide maybe pins and needles or numbness into the fingers, it's very much the lower neck. So that's C7, T1 junction. It is in that location. What you'll find is if it's further up into the shoulders here, maybe it's around C4-ish, into the biceps, maybe C5, C6. So it's just different things I'm giving you. If you look on the internet, you've got all those myotones and dermatome maps anyway. They're really quite easy to follow. So if you want to have an idea a little bit more than I'm giving you, please feel free to go on those. You'll find that each dermatome map is just slightly different, but it's just giving you an idea because we're all wired just a little bit differently each time. But again, so sometimes you may have pain referral, sometimes you might have that numbness that we talked about, sometimes you might have that pins and needles that will go into the shoulder region, maybe the biceps, the triceps, or all the way even down into the fingers as well, yeah? So if we're looking at the lower back, if there's area issues with the lower back, then it may present into the legs, okay, the lower extremities. If it's into the neck, it may present into the arms. The thoracic spine itself doesn't tend to present into the arms at all, maybe underneath the armpit into the back side of the arm around this area, but as a rule, that would be very much the top, say T1. The rest of it doesn't really, it just tends to stay in this sort of rib cage area. So that's your common back pain presentations. These are the things that people will come in with. And if they have been diagnosed, all I'm doing is just giving you a little bit of information to say, okay, yeah, I know what's going on, or I have an understanding of what's going on. It's not trying to make you into a physio, it's not trying to make you into a clinical expert, it's just giving you the background, so it gives you, you feel a little bit more confident when you're actually giving an exercise program. So I'm just going to put this back up here, and then I'm just going to change the slide through. Oops, we skipped one. No, we didn't. So basically, I just picked up this slide, and this slide is from the internet, so it's not as if I've chosen it for any other reason than it was a swan dive. And I just loved the way that there was this positioning and it's actually held. So if you look at the traditional swan dive and look at Joseph, the way he does it, his arms are wide and he really is maintaining that perfect bow in the back. There is no movement through the actual spine itself. The muscles are working isometrically as he moves upwards and back. So the chest goes to the floor, the hips go to the floor. It's all very much controlled. And this is what we're looking at, is those muscles that create that. Of course, we can do our starting exercises like our breaststrokes because they all build up along with the swan dive preps. But what I'm actually looking at here is what muscles are really involved here. So within the body, you've got a layering of muscle system. Now, I'm not going to tell you that each muscle works individually because they don't. Every muscle works in a group, and there's a complete chain of events because the body is a unit. It cannot work on its own. Even if I scratch my forehead right now, I can tell you there's a whole chain of events that's gone. It's not just this little finger moving to doing this. Okay, so it's a whole chain. And this is what we need to think about. Even when we're doing correcting or looking at a corrective form of exercise, and when we start talking about individual muscles, we are looking at the chain of events. We're looking at the muscle firing pattern. So if you look here within this exercise, what you're actually seeing is those big muscles, the superficial muscles on the outside. They're like the erector spinae muscles there. You can see the glutes are working all in red, and also the hamstrings. And then of course, you've got deeper muscles than that. So maybe the next layer down would be something like the quadratus lumborum, maybe some of the smaller glute muscles, maybe some of the smaller back muscles. Then of course you've got deeper muscles still that really support the spine. Those will be like the multifidus and the rotatorius and things. So I'm not trying to give you an anatomy lesson, I'm just giving you an awareness that there's really, really deep muscles that really help stabilize the spine. And there's those ones in the middle that do a little bit of both. And then of course, there's the ones on the outside, the big superficial ones, the ones that we want to pump up, the aesthetic ones, nice rippling back muscles or lats or whatever you want to look at. And they will actually be more of the superficial muscles. They are the big mobilizers. So every muscle group has its task, it has its role to do. But of course they do integrate as well. It's not as if it, just because you move at one stage you're using this muscle and then you're using this and then you're using this. They all work together. But what happens is at some stages of the lever length, one group of muscles will overtake the others while the others take a little bit of a back seat. That is all it is. It's even like in running. If I was running a marathon, for example, I don't necessarily just use my aerobic system. Of course, what I'm going to be doing is I'm going to be dipping in and out that anaerobic system as it starts to get a little bit more challenging, before maybe I need to drop back in my speed and then tune back into my aerobic system again. So the body is working exactly the same way. It's dipping in and out of what it needs at the time. And if it's working perfectly, it will do that really well. It's when it doesn't do that really well, then of course injuries may happen, and that's just where the tissue breaks down in compensation, maybe 20 years later, and something just happens. It's like, as they say, it's the camel that broke the straw's back, or the straw that broke the camel's back. It's as if someone just bends down for a piece of paper or a pencil, and suddenly they're, oh my God, my back hurts. It's not that hurt their back. It's the 20 years of whatever they were doing in order to do that in the first place. So it could be their bad posture for 20 years. And the body's just gone, I can't do this anymore. I can't compensate for you anymore. I'm just letting you know that, okay? So that's all it is. So then coming into this one's quite an interesting structure because it's Lee and Bleeming. It's a real big studied area. It's the model of joint function. And why am I introducing you to this? Because it is a bit of theory. But I'm just trying to give you an idea of what a joint may or may not look like if it was congruent or if it was working perfectly. So Lee and Bleeming in about 96, where it says 1998 there's various papers out there, so please have a look at it. What they're looking at is they look at 4 sections that actually create this perfect alignment within the joint, the perfect congruency within the joint. And they're actually looking at both structure and the function of that joint. So the 2 areas that are the most important, which is what I put down on this slide, is actually the form closure and the force closure. So the form closure is your passive component. So if we're looking at the spine again here, then that'll be the bones, that will be the ligaments that are obviously not on this spine. It will be the cartilage. The cartilage in this case is the disc, yeah? So that all of that area would be that there. So the bones, the joints, the ligaments, and that cartilage area. Where the force closure would be the slide previous to that, where it was all about the muscle and the fascia. So the fascia, there's lots of stuff out there now. In the last 10 years, it's become really, really popular to be doing fascial movement. If you look at the father of osteopathy, Andrew Taylor Still, of course, he discovered fascia back in the 1800s. It's just become a new thing. What is fascia? Fascia is just a surrounding, like a saran wrap or a cling film to the muscles and the rest of the body. And of course, it brings about the body being a complete unit. So at least when we keep thinking about doing our exercise programming, there's lots of things about saying, yes, work glute med, work this, work that. And I do dip into that, but I never forget the body as a unit. We're actually looking at the body as its entirety, not just trying to fix one element of that. So the form closure is your bones, your joints, and your ligaments, whereas the force closure is your muscles and the fascia, and obviously that surrounding muscle tissue that brings about the joint. So what does that mean then? So if you think about it, if we have the form closure and the force closure together, if they were doing exactly what they should be doing, then that joint should be 100% congruent. We're going to look about the motor control and emotions awareness in a minute. But basically the passive and the active component together should make 100%. So let me think about that. So let's have a look at maybe a joint that's not quite so stable, like the shoulder. So we know the shoulder joint itself, it should be a ball and socket. So it's got this little cup, which is the glenoid cavity. It's got the head of the humerus. And actually it's more like a cup and saucer rather than a big ball and socket joint. And it's quite unstable because it needs to be functional. So it needs a lot of mobility for us to be able to reach overhead. Whereas the hip joint, if you look at the same ball and socket, is much deeper. So it's a much more sort of like, shall we say, structurally or form closure wise, a lot more fixed and a lot more stronger, it's got more strength, yeah? So then if you look at the shoulder again, we need a lot of muscles to help stabilize that joint. So if you think about it, you've got lots and lots of things like the rotator cuff muscles. I could go into a list of them, but it's about 33 to 35 different muscles in the shoulder and shoulder girdle that help stabilize that area. So it just gives you an idea of how many muscles that could potentially be imbalanced if we didn't get it right. So you've got your form closure, your bones, and then your muscles. So you can imagine if you've got that bad posture, how easy it is to create that imbalance and that lack of congruency in the joint. However, if it was perfectly fine, what you'd have is the muscles doing their job, the bones and joints doing their job, and there'll be enough space in the joint to create tautness on the ligaments, and it wouldn't be too wide, but it also wouldn't be too compressed, which would create shearing. Okay, so that's your structure there. So if you look at maybe that shoulder joint again, maybe the bones and joints or the form closure is about 30% of congruency, whereas the muscles potentially could take up to about 70%. Now remember, I'm just making these things up. I'm just literally telling you that's a rough idea just looking at the structure of the joint. However, if we went to maybe the skull, like the sutures of the skull, so unless you're a craniosacral therapist, which of course I am, what we actually believe there is slight movement, but anatomically wise, if you look at Gray's Anatomy, they say there's zero movement in the sutures of the skull. So basically the form closure itself is 100%. It really doesn't have to rely on the surrounding muscles of the force closure in order to keep it congruent. Does that make sense? So you've got something like the shoulder joint, a bit more mobile, the sutures of the skull, not so mobile. Or you could relate that to the hip joint. The hip joint itself is still a bit deeper in the structure, so potentially maybe about 60% through its structure of its form closure and maybe 40% on the muscles. Yeah, because there's lots of muscles around the area, but they tend to be very much about motoring forwards, plyometrics, and actually getting you to transport and move your body from one position to the other. Whereas the shoulder is very much more about stability before it brings about that movement. Now, those last two things I'm not going to go into great detail about, but of course, number 3 is talking about the neuromuscular pathways. So it's looking at that transmission, that sensory and motor control of the nervous system. You're getting the messages from the brain and back to that muscle to help it move and help it sit in its correct alignment. And then, of course, you've got emotions and awareness. Now, we all know clients come in maybe with similar conditions. No condition is ever completely the same. But what you might find is 2 people with similar back pain, for example. And actually, one person's really upbeat and actually has a great life and loves life and is just buying another house in Spain and, has no money worries and has a great job, has a great relationship. Whereas the other person maybe not have those sort of things. So their emotions could actually create maybe bad posture, an effect on their body. Their body may feel more pain because of it. Also, body awareness is the key. So those clients out there that seem to have zero body awareness. You say, press your heels down and they do something completely different or nothing at all, or put your hands there and you're thinking, how many times have I got to say the same thing before they actually do it? I know. We've all been there. And, you almost direct your gaze at them. Yes, I'm looking at you. But ultimately, again, if you think about it, having body awareness of where that positioning of that joint should be also will create that congruency in the joint. So really, this is just background information as to why or why not something may or may not happen, okay? So looking at our muscle classifications. So again, I just wanted to touch on this. I'm not going into great detail on this, but if you do want to go further, the muscle classification system was by Mark Comerford. So if you look at performance stability, he's done a lot of papers on muscle classification system. It's something that I've taught through injuries and special population courses. But I just wanted to touch on it rather than go into huge details. The other thing is the sling system. So the sling system is about the myofascial sling systems. And if you look at the sling systems, you will also see that this comes from the likes of Anatomy Trains, Tom Myers. There's other people as well, but these are the most common books that you could easily pick up from the internet read in your own time, and just have a better understanding, maybe of some nice pretty pictures as well. So I'm quite a visual learner, so I like to see pictures rather than just writing. So the reason why I chose on this is because I really want to look at maybe our exercise programming and why we're choosing certain exercises. If we're leaving some out, why are we choosing others? Because of those type of conditions. So I already hinted to the fact that we have a layering system of muscles. So we have what we call the local stabilizers, which are deep to the spine, and I hinted to the fact that they are things like rotatorius, multifidus, similar like that. You've also got the global stabilizers, so they're the next layer out, and those are the ones like, I don't know, quadratus lumborum, if we're looking at the front of the tummy muscles, of course, more like the obliques, whereas the local stabilizers of the abdominal muscles would be things like transversus, pelvic floor, diaphragm as well. Remember that we're a three-dimensional creature, it's not just front and back. So all of those local stabilizers, global stabilizers would be obliques, QL, yeah? The global mobilizers are the big superficial muscles. They're the ones that if a saber-tooth tiger came running into the room now, you'll be off like that. You'll be the fastest dinosaur in the planet. I'm not sure if the dinosaurs and saber-tooth tigers were on the planet at the same time, but anyway. So the whole point is that you will be running. They're your locomotion muscles. They're the big aesthetic muscles. They're the ones that if you looked at the beautiful Arnold Schwarzenegger in the day, you will see them rippling out of his body. So that's what we're looking at. So you've got the deep muscles trying to support the joint or the spine in this case, and the big ones trying to move that spine. What actually happens in injury, in a lot of us, we become a bit deconditioned, and what happens is our little local stabilizers aren't really doing the job. They're either wasting away because they're either overstretched, or maybe the joint is not particularly congruent, so they can't actually function because there's none of that neuromuscular messaging coming through. And what may potentially happen is the global mobilizers overtake. So what they do is they try to stabilize, but when they're asked to move as well, they have to try and do both, and they actually can't do both. So a classic example of that is if you were looking at someone's back, for example, and you lifted up their t-shirt and you saw one side was a little bit more muscular than the other. So one was a bit hypertonic, say. Well, that hypertonic side could be your global mobilizers in spasm, whereas the other side is not. Now, anything in spasm is in spasm for a reason. It might not just be the muscle, for example. So it could be there's something going on wrong in the discs. It could be there's something going wrong in the facet joints, or it could be muscle spasm. But normally it's something else, right? A muscle doesn't just spasm on its own for no reason. There's always something underlying it somewhere along the line. So what we want to do is work from the inside out. So again, if we're looking at trying to correct or a corrective pattern, we're looking at low load, we're looking at closed kinetic chain. Closed kinetic chain where the feet is in contact with the floor or a hard surface. That means you can actually try and work predominantly in neutral or an imprint, it doesn't matter, but actually really trying to stabilize through the whole center of the body before you start to then introduce higher load, more open kinetic chain exercises, but they will be layered in. We don't want to just be stuck in this low load, what I call rehab hell, yeah? We always need to go up the continuum. So just think about your continuum of Pilates. Sometimes you're a little bit rubbish and sometimes you're absolutely excellent. So you might need to start down at this side because of course what injuries happened. You then might progress even up to the top end. It might be 20 years down the line and suddenly you have to come back down a bit because you're a bit halfway. And then guess what? Your back starts hurting. So you might need to come back down here. So it's a continuum that you will be going up and down. We will all be doing that all the way through our lives as we age as well. It's not necessarily the return of back pain. It could be just age. Okay. What I really want you to take home, I should have highlighted this, underscored it. Find the give and the restriction. That is the most important thing. So if something is moving too much and something else is not moving too much, guess what you got to do? You got to move the restriction and you got to support the give. So the classic example would be the lumbar spine is taking everything, maybe L2, because you're bending around all over the place. Have a look at someone doing the swan dive. When they do the swan dive, they come up into that L2, don't they? And you're like, oh, can you not pull your tummy muscles in to support that? They hinge, they literally drop their stomach. So again, we're trying to get them to control that, to try and get that even extension. But they might just drop out, so they might just move through there. But the thoracic spine does absolutely nothing. So what we're trying to do is get an extra movement through the thoracic spine. That's why the likes of the breaststroke preps are so good, because we're trying to get that movement through the thoracic spine before we go into full spine extension. So this is what we're trying to do. We need to mobilize that restriction, and then we need to fix the give. So what we're actually doing is we're creating a dissociation of a particular area. So the classic example of that would be you're lying on your back, you're putting your tummy muscles in, you're either doing a gentle leg slide or even a knee drop, yeah? But the body itself is staying completely still. Now, I know people out there will be saying, well, you don't keep it completely still because there's still rotation. But what we're trying to do at the moment, this is a little bit of a just post-rehab, trying to disassociate the hip joint from the spine. So you're trying to keep the spine as stable as possible at that point. And guess what will happen? Oh yeah, they'll start to work the obliques, the abdominal muscles, whatever you want to call it. But literally they will start to feel that some form of muscular control is happening from the torso. It's happening from the center of their body. And then, of course, in time, we don't want to just leave them with this disassociated physio-type exercises. We want to reintegrate it. So even when we do something like the full hip release, although we are trying to keep that stability as much as we possibly can through the torso, there may be some form of dynamic stability through the torso. There might be a nudge in rotation, but you're still supporting it with the abdominal network, with the muscular network, yeah? So it's not about just letting everything fall over, it's about that control in the dynamic aspect. So this is all we're leading to. We always want to lead to that dynamic stability, that dynamic control, rather than fixing everything dead or just giving away and let everything go and do its own thing. So that's what I'm thinking. Find the give and the restriction, fix the give, and mobilize the restriction. So I'm going to keep saying that all the time. So then the next stage, just to look at maybe a little bit underlying theory to your sling systems. The ones in particular that I really like to concentrate on are what they call the posterior sling system, the anterior sling system, the lateral sling system, and the longitude sling system. So what you have here is 4 key points. And actually the hint is there because what it's telling you is the muscles that's involved. So a posterior oblique sling system goes obliquely across the body. So it's actually saying the lats maybe on the right side, going through the thoracolumbar fascia, and it's going through the glutes on the other side. And if you want to continue that down, that goes into that adductor. The same thing with the anterior oblique system. It's going through the pecs, the obliques, opposite adductors. So again, you've got that oblique sling system. The lateral side is just the outer side of the hips, the abductors and the adductors. So you've got those 2 points. And this is really common in maybe people that have a longer leg discrepancy, maybe a scoliosis or something like that. You'll see that one hip is slightly higher than the other, or potentially could be higher than the other. Then you have the longitudinal sling system, which actually really, if you think about it, the swan dive is, you've got the erector spinae running through, then through the thoracolumbar fascia, then into the sacrotuberous ligament, into the hamstring, certainly bicep femoris runs down. So what I've done is I've given you key examples on how Pilates works those systems. So in fact, if you did the whole system of Pilates, if you were looking at the 34 exercises of Joseph Pilates, you would target all of these sling systems. So in fact, the great thing about Pilates is it's actually done the programming for us. All we need to think about is what is relevant for that person right now in their injury, and how can I then maybe progress them to the full exercises. So we might need to modify some of those exercises, certainly if we're only working with the mat and we haven't got the apparatus or equipment to do that. So we need to modify it first maybe, or omit them, and then slowly integrate them so that they can work up that continuum that we've been talking about. Okay? So then moving on to the next slide. So now we're just looking at some of those exercise examples, which I was talking about really. This is just for you at your own time. So you might want to think about what are exercises? What can you think of? Can you think of exercises that target specifically maybe the deep lower muscles? Now, I've already told you, really, muscles work in patterns. They all work together. But if you keep the exercise low enough, then actually the big superficial muscles shouldn't work, because the superficial muscles are the mobilizers. So if you're doing a little gentle leg slide, for example, there is no reason that the rectus abdominis needs to kick in at that point, because it's a flexor of the spine. Are you flexing the spine when you're doing leg slides. No, your spine is actually just lying there. It could be an imprint, it could be neutral. An imprint is maybe shortening the obliques a little bit. It's actually just a flexion bias. It's gapping the facet joints. That's all it's doing. It's not a big, deep flexion. It's certainly not using the back muscles, and it's certainly not using the glutes. So just be aware of how far you're going in that imprint. That imprint could be just basically your breath, breathing in and shortening the distance between the ribs and the hips. It could be that subtle, okay? So local stabilizers, so your basic principles. And that's the great thing about the Stop Pilates method in particular. The basic principles are their USP. Yeah, they really do put the foundation to Pilates in place. So use them. I know that when I very first did my Pilates, I was like, oh yeah, right, really want to stick with the basic principles. But actually, when you go back to them after you've done the full system, you realize how amazing they are. They really are going to help you get a stable base before you go into your bigger Pilates moves. So then you've got the likes of your global stabilizers, as I've talked about, the obliques, the intercostalis, serratus anterior, all of these sort of things. So again, I put essential repertoire down there. Okay, so it could be essential repertoire mat, reformer, otherwise. So what you'll find is, I find in a lot of injuries, although I will use bands and balls and things like that, so I can do a mat-based workout, and certainly for homework I will do that. But what you may find, if you are an apparatus trainer or equipment trainer, you might find that you need the support of the equipment initially, or at least have some form of support of additional stuff like bands, circles, to help your client, or keep them in a low load closed chain exercise on the floor. So again, the global stabilizers, they're just working a little bit deeper, a little bit more movement, still got the foundation, the basic principles in there, but you're starting to integrate some more movement. So again, you know, look at things like swimming preps, for example. So your full swimming is about challenging the body in side bend and rotation with those contralateral arms and legs. But actually a 4-point kneel approach, you're still doing the same challenge, but it's much slower, it's much calmer, and you're almost trying to disassociate the hip and the shoulder joint from the torso initially before you reintegrate that in and get that further challenge with speed and also lift, yeah? So then, of course, you've got the global mobilizers, erector spina, latissimus dorsi, rectus abdominis. And again, this is looking more at the intermediate and advanced. So the prime example, of course, for that would be something like the swan dive, because it brings you up into extension, and of course you held there as you rock. So again, these are some of the exercise examples that you could just start to think about. So if you think about those examples that we've just discussed, I'm going to leave this with you so you can now think, what sling system is that using? So hinting to the fact that the erector spine, I remember I'd already hinted that it's a longitudinal sling. You might want to pick up on that. But also pick up on the fact that if you look at the body, when you're looking at an extension, what you also might see is the latissimus dorsi connect, and then that can go all the way through the thoracolumbar fascia into the glutes as well. So you have a bit of a mix, don't you? So you'll find that maybe some of the exercises do cross over from one system to the other. But I'm going to leave you with that so you can do that in your own time, if that's okay. Okay, so moving on to some of the actual factors, or some of these, I'm going to move me actually out of the way, some of these conditions, okay? So firstly, one of the most common back conditions is a herniated disc. So what we're saying, some people say herniation, of course, some people say slip, some people will say prolapse. These are all common terms. If you look in research, I'm sure each of them, if I remember right, is a certain percentage more than the other. But actually for us, all we need to know that there has been some form of prolapse disc or herniated disc. I even like bulging discs, and actually I've even used before, which is completely non-medical, that is a grumbling disc. That disc is not very happy. So again, you've got all of these little weird diagnoses that many of us use that actually are not real, yeah? So just be aware that this is what, it's one big bag fits all. So we've already hinted to the fact the most common area for the disc prolapse in the lumbar spine in particular is actually L5S1, which is that wedge-shaped fracture. wedge-shaped vertebrae, and L4, L5. So what could commonly happen is L5S1 goes, and then later on maybe L4, L5 goes a little bit later. Not in all cases, but that does tend to be a bit of a pattern. In the neck, however, I must admit it's a little bit lower. It tends to be about C5, C6 is the most common herniated disc. So I'm just throwing that in. I know really I'm more about the back rather than neck, but I am letting you know that it's more of the lower neck. So it would actually present potentially into the arms, yeah? Maybe just even towards the elbow, maybe not all the way to the fingers, but certainly it gives you an idea if you've got clients in that situation. So with any disc issue, it's really aggravated by sitting, slouching, flexing forward. Oh my God, how are people going to put their shoes on? How are people going to brush their teeth? So you'll find that a lot of those ADLs, or those active daily living, the actual things that we take for granted, are actually really painful. So they're actually relieved by lying flat, maybe standing, or even extension, yeah? So you'll find a range of exercises the physio, if they get a chance to see a physio, we'll give them maybe 3 or 4 exercises, which we'll discuss in a minute. So they do tend to be given those. Looking at the stages, of course, what you'll find is that there's acute stage 0 to 3 days, subacute is 3 days to 3 weeks, subchronic is 3 weeks to 3 months, and then anything that's been in chronic pain over 3 months. This is the scale that we tend to use. As a rule, as a Pilates teacher, we are very unlikely to see anyone in the acute or the subacute phase unless they've decided to come to us, but unlikely if they're in that much pain. You're probably going to see people in that subchronic to chronic stage. All right, so just giving you an awareness of that. So again, we need to start thinking about what type of exercises are relevant for these people, and maybe what type of exercises you can or can't leave out. What you will also find with your disc, you will potentially have some form of muscle tension. Hypertonicity is tightness in the muscle, yeah? So you might have a look, when I gave you that example, looking up underneath the top, you might see that one side of the back is very much in spasm. So that could be the erect spinal, but it could easily be QL. Quadratus lumborum is really big in that. Also, what you might find with back pain is people's hips start hurting. So the psoas starts to really pull in, because again, can't find the lower tummy muscles, so the psoas is trying to do everything. It's trying to stabilize, it's trying to get the tummy muscles in, and it's trying to move that hip and back. Because remember, the psoas is attached right up to T12, so it's moving the spine. It's responsible flexion, extension of the spine, as well as that flexion and extension of the hip. So in effect, it's actually doing quite a big deal in comparison to the iliacus, which is attached right in the inside of that ilium. Okay, so psoas sometimes plays a part in a lot of back pain, erect spini, and of course also glutes. Another thing I've noticed within glutes with people with back pain is they're not necessarily, they are weak, but they're not weak in the sense that you think, is they tend to bum grip. And bum grippers tend to be flat in the bum. And those people also are potential for back pain, because they don't actually realise they're bum gripping, and they can't feel their bum working, because actually the only way they can is by gripping. And what we have to do is teach them to loosen the bum, so therefore they can actually feel a different part of the glute engaged, maybe by the heel connection. And actually they go, oh yeah, I can feel that work now, but in a completely different fashion to what they've been doing for years. So what you'll also find with herniated discs, certainly if you've looked at the MRI, you might find that they talk about the ligaments being hypertrophied. So basically the size increased in the ligaments. So there could be ligamentous strain as well. Any hypertrophy of the ligaments could start to irritate the local nerves. Obviously those messages will be sent backwards and forwards to the central nervous system, so that could bring about pain as well. So although ligaments themselves don't actually have nerves inside them, lots of things are around, the structures are there, nerves are around everything. So even something like a disc, for example, there's quite a lot of people go around with a herniated disc who have no idea about it, because the disc itself is only innervated on the outer third. So if it passes out just a little bit and it hasn't got any irritation of the nerve, then people just walking around with it, they don't know. So there's a lot of people out there that have no idea that they have this. So it's common, so don't be scared of it. Yeah, we're still walking around quite well without that knowledge. So again, just hinting back to what we talked about earlier on as far as the presentation. So your associated nerve irritation and or impingement could create some form of pain referral into the legs, whether that be anteriorly If it's the upper lumbars, maybe L2 to L4. So that when I mean anterior, I mean into the thighs, maybe into the, not necessarily the shins, actually the thighs or the adductors. Okay, but if it's the lower lumbars, L4, L5, and all the way down to S3, you will find that that referral pain could come through the back of the thighs, so into the glutes, into the hamstrings, into the calves, and even down into the feet. So you could find there'd be a bit of numbness just on the big toe, and it could be something like this. It might not be, so don't say that it always is, but I'm just saying there's a little bit of numbness in that little toe, and you know that they've had their diagnosis. That could be just a little presentation of it, okay? If it's something new to them though, please refer them on, because it might not be that, and I won't go into that detail right now. Okay, so again, loss of power may be apparent. What is a little bit more scary, which I haven't really put on here, is if someone has pain presentation or shooting pain through both legs all the way down to the feet, and if there is some form of what they call saddle anesthesia, so where if they wipe themselves or go to the toilet, they can't quite feel themselves. That really is a bit of a medical emergency, and it could be what they call a cauda equini. And if they do have anything like that, please refer them to A&E, because it is a medical emergency. Okay, so unlikely, it's very, very, it's not particularly common. There's been a few people out there that I've seen with it, but it's not overly common, but something to just be in the back of your mind if something happens that you think, I'm not quite so sure about this pain presentation. What I will always say with pain though, if the pain changes in any structure whatsoever, they need to go back to their medical professional just in case, yeah? Okay, so exercise programming for herniated discs. So there's a few things. I talked about the exercises that physios might give them. They'll give them things like cat stretch and modified cobra. To us would be like a modified swan dive. They might do the glute stretch where you take the leg over the leg, hug in, or a pigeon or similar. So they'll do all that just to relieve any tight muscles. And these tend to work on a small basis, but of course you want to get them moving and maybe working their tummy muscles a little bit better. So what we need to think about is the movement pain-free? So we need the movement to be as pain-free as possible. That's so important, because you want to be trusted for a start. And remember, they're fairly new to this for you if you're looking at the subchronic to chronic. What we need to look at is a neutral spine pain-free? And if it is, that we're working towards neutral. If the neutral spine is not pain-free, you need to then still keep an imprint until neutral is comfortable. So you're having the feet in contact with the floor. You might do some leg drops that we discussed, or leg slice, just to stabilize that neutral, to make sure they're happy with that. And then of course you're going to start to teach them a bit of Pilates. Now really what you're looking at is, what do I introduce? What are the exercises that I need to sort of like just leave out for a minute? If it produces pain, then we're just leaving it out for a bit. But actually the order that I like to think about is, once I've done some form of stability in neutral, and I know that there is some muscles working in that abdominal core, what I want to then start to introduce is movement through the spine. So remember, movement is key. Movement is where the spine gets its nutrition from the above segment. Yeah. So without movement, that nutrition isn't dropping through. It's like gravity. It needs to drop from vertebral body to vertebral body. So it's extension of the spine is what we need to. If you think about it, if that prolapsed disc, and this one is quite a good example, there's a red thing here, is most commonly posterior lateral, sometimes posterior, but mostly posterior lateral, then of course you don't want to flex it to allow it to almost feel like it's bulging out further, which could cause more irritation around the local nerves. So if you extend it, it's doing the opposite. So that's what we're thinking about, is we're trying to bring some extension moves into the spine in a pain-free range of movement. Then of course, where do we go next? Let's have a look at side bending. So side bending away from the prolapse might cause impact. So just be aware of that. Side bending into it probably will be okay. But what we need to do is we need to even side bend one each way. We can't just do side bend one side and not the other. So if you are doing side bend, try to avoid just collapsing. Think really reaching nice and tall, and reach up before you come over. So it's almost like you're a tree growing and swaying in the wind, and you're just lifting and reaching to the ceiling. reaching and lifting to the ceiling, and then you'll get the stretch and the traction through the spine that you need, and you'll get your even side bends. Just be cautious with it, but add it in. Upper body flexion. Now, I've actually put in upper body flexion before rotation. The reason why is I've seen a lot of people with surgery that have had discectomies or similar, and the surgeons are very much no rotation, because of course, as I hinted, there really is minimal rotation in the lumbar spine, and if there's no disc there, it would only cause more shearing and damage to any underlying vertebral body, certainly if it's not being fused. Okay, so if there's no fake disc being put in there or nothing that's actually holding that gap in place, the gap will slowly dissipate. And of course, what you're making sure then is there's none of that shearing on that joint. So it's a lot of surgeons that require this, so just be cautious with your rotation. So what I'm going to do is put in upper body flexion first. The upper body is through the thoracic spine. So if the lumbar spine is not compromised, now of course we know the body is a unit, there will be a minuscule bit of flexion all the way through the spine, but as long as they can do this upper body flexion, they got the abdominal engaged, guess what? They can go back to brushing their teeth as they want to lean over, all of those things that we take for granted. They're going to be able to do pain-free, and that's what we're trying to do. Then with rotation, we are going to add it in, but just a little bit. So I don't want you to pulse round at end range. I want you to almost spiral as you grow and come back. You might actually need to start with maybe a band under the thumb and start off center first and then pull back to center. And so you're pulling against the band and getting the work through the waist that way. And eventually doing full range. I always want full range of movement in the end. I don't want to restrict people's range of movement. I want them to work evenly. I want them to work with that lovely space in between each of the vertebrae. I want them to work complete articulation through the spine and not just in one area. And that's what we're encouraging them to do. We're encouraging them to get that movement, that pain-free movement all the way through the body, because movement is great. And eventually you want to then add in lower body lumbar flexion. So I know a lot of people are really, oh no, can't ever do that. You can't do loaded flexion. So loaded flexion is where you would slump into your lower back. So anything like sitting, for example, and slumping, something like the half roll back, the obliques roll back, anything like that could be considered loaded flexion. So what we do need to do is we need to control that. So if they haven't got the control and they're still in pain, then take it out. Just look at ab preps or maybe half roll-ups or something similar. Just take out that loaded flexion until they can do it. Maybe you haven't got any of the equipment, or in your head you can't understand what that is. If you use maybe the equipment to do your lumbar flexion, what you'll find is you'll get more of the lift that's expected from Pilates, so you'll get more of that lift out of the lumbar rather than loading into it. So sometimes it's actually really good to ensure that you eventually work down your Pilates education and ensure you end up also training yourself in the apparatus and equipment, because it will help you in the long term. But I do understand that many of you are teaching mat classes. That's absolutely fine. Just be aware of you might be doing your gradual aspect up that continuum just a little bit slower, okay? Don't worry, they'll get there in the end, but you're just avoiding lumbar flexion. It doesn't mean to say that you're never ever going to do that exercise ever again. Okay, so that's the disc. So the discs prefer predominantly neutral if it's a posterior, lateral or posterior disc bulge. That you can get anterior disc bulges. They're not as common, but you can get them, and they tend to happen through trauma and maybe in the thoracic spine. So again, as I've told you, there's not often you get disc prolapse in the thoracic spine, but say for example, if someone dropped a barbell on themselves, you probably would end up injured in that way. So if you have an anterior disc bulge, you're going to treat it in the same way here as the facet joint irritation. I didn't want to confuse you on the last one. So facet joint irritation, often called a facet joint capsular irritation or a capsular irritation. And the reason why is the facet joint is a synovial joint. So if you look at the facet joint, what you've got is you've got the joint here, and I know it's not here, but then you've got a little capsule and you've got the fluid and you've got the cartilage in the actual facet joint itself. So it's made up in exactly the same way as the knee. Yeah, so if you look at your typical structure of knee on your Google or wherever you are, or you've drawn it probably doing your anatomy courses, just think about that and really, really tiny, and that's where the facet joints are. But what can happen, obviously, with bad movement or movement that's just irritated, the membrane can get caught between the facet joint itself, and that's what it means by capsular irritation. The membrane is innervated. Yeah, so although the cartilage itself is not necessarily innervated completely, the membrane is innervated. So of course that will bring about pain, and that will send messages up and down the brain, say, ow! And then of course certain things will be painful in movement, in particular extension. So these facets can override with age. Why would a facet override? It could be wear and tear of the disc. So in this place, it says actually degenerated discs. So discs that lose their height. And unfortunately with age, we do all start to lose the disc of health. So guess what? We're all going to have some form of degeneration through the disc. So please don't sort of like get scared or stressed out about it. It happens with age, yeah? So it slowly starts to dissipate. So it's not a great diagnosis if someone goes, oh yeah, I've got degenerated disc. Haven't we all over the age of 40, yeah? Okay, so basically, if you have a degenerated disc, the facets might start overriding, and that may cause that capsular irritation. Also, something called stenosis. And the stenosis, again, is these might override, the discs have degenerated, and actually this lateral foramen here, that gap closes. So therefore there's an impact on this nerve. So this could create numbness, pins and needles, pain, irritation. And so that's what stenosis is. This could close up. It could even start to reduce in its space if there's arthritis in the spine, and there could be little osteophytes. Now, osteophytes are little bone growths around the area, and it actually starts to occlude the hole, and therefore stenosis takes place. One of the other conditions there is spondylolisthesis. Try and say that fast. Okay, what you've got is the curve of the spine. So imagine L2 keeps going, doo, 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 and eventually it starts to pop forwards. And so you've got 4 grades of spondylolisthesis. The first 2 normally is catered with exercise and maybe anti-inflammatories. Grade 3 and 4 does tend to have some form of surgical implication, but literally this is going forwards. And if it goes forwards too much, what happens is the lamina breaks, and then the back of the spine breaks away from the front. So the vertebral body actually breaks away from the processes, yeah? And that is what's called a spondylolysis. So that's a fracture of the spine. So sometimes they work separately, sometimes they work hand in hand. There is also a condition called a retrolithesis. It happens in about 5 or 10% of the cases, if I remember right. But that is where the vertebral body goes backwards. So sometimes you might have seen that. You might have seen someone, when they flex forwards, they've got this one lump, and you're thinking, what's that? And it could be potentially where that vertebrae is starting to ooze posteriorly. What do I do with that? Well, that you actually treat in the same way as you treated the disc. So I'm just going to throw that in there. I'm not going to spend lots of time on it, but just think what we said about the disc. Your retrolithesis would be treated in the same way, whereas the facet joint is very much spondylolisthesis. And then the last term there is ankylosing spondylitis. Now that is actually an autoimmune disease, and there's lots of diseases that affect the spine, but ultimately I just want to focus on this one a little bit, because actually this is getting more and more common. More and more people are being diagnosed with this. Initially it was very much young men diagnosed with back pain, maybe in the sacral area, and then they would have an MRI and they'd noticed there was fusions taking place. So ankylosing spondylitis is the it's an autoimmunity. It's where actually the spine starts to fuse, and actually under a microscope, an X-ray, you'll see the spine has very phased and blurred edges, and they start to call it a bamboo spine. It's where the connective tissue starts to harden as well, so it becomes not very flexible. So people with ankylosing AS, should we say, they could actually really be flexed through the thoracic spine. They could end up being very extending that upper lumbar as well. So they could actually start to simulate a sway back, yeah? There's also other people where they're really fixed in their tall, and they're actually really tall in their spine, and they actually can't do much movement. Now, with AS, mobility is the key. You must articulate that spine. I don't care where you're articulating, you articulate the spine, yeah? Make sure it's pain-free, articulate the spine. If someone's fused in their flexion through the thoracic spine, you probably won't be able to do much extension, because the extension will come from that upper lumbar, but you can do standing and kneeling work in an upright position, can't you? You don't have to extend them, or you could start them in a flexion and bring them up to a predominant neutral. So just think out of the box sometimes. Don't just be going, oh my God, I can't ever do that. That means that, you know, that's 5 more exercises taken out of my repertoire. Think a little bit out of the box. So aggravated predominantly by standing for a long time or extension. Now I say standing, it's because if people are in that extended position while they're standing, that's what irritates it. But if they actually flex forward or knee hug, sitting, all of that actually relieves the pain. So guess what? We're going to be doing exactly the opposite of what we did with the discs. So again, you could have some form of associated muscle hypertonicity. There could be some nerve compression or irritation too. But again, this is what we're going to be doing with it. Yeah. The great thing about facet joints, there is a great blood supply and they heal really quickly. That's one thing I didn't say about the discs. The discs don't heal quite so quickly because they don't have a direct blood supply. The discs can take a little bit longer. They can find that people really still have pain in that area up to about 9 months later. The tissue itself around it should be healthy, and sometimes it could be the nervous system playing tricks where the nociceptors or the nerve cells get overexcited and irritated. However, it does tend to be a bit longer. Whereas a facet joint irritation only takes a matter of weeks to get over because there's that fresh blood supply. So how are we going to deal with it? So the exercise programming for the facet joint, of course, is an imprint bias. So we're working more in an imprint. We're working more flexion. We want to be in a pain-free range of movement. We're still stabilizing the spine first, exactly the same way as we did with the disc, but now we're imprinting. So it gives it that slight gap in that facet joint is just opening in the back. It's not overly flexed, it's just gapping a little bit to release the pressure of that overriding. So leg slides and knee drops are an imprint. You could simulate some of the physio-based exercises like hip rolls and cat stretches and knee hugs and shell stretch. So all of those sort of things will help, yeah? What you might find with people with facet joints with hip rolls is they might roll up too high and then pop their rib cage and then hinge through their maybe upper lumbars. That you just want, that's for your own cueing. That's just making sure the rib cage is connected, making sure you don't come too high, maybe think more long line rather than up to the ceiling. So again, you can still do the exercises, but just maybe your cueing needs to change. Maybe you only do a hip roll up to the lower thoracic spine, maybe T12, and don't go any further. So then the rib cage is engaged and you can feel that gapping of the lumbar spine. Then slowly progress into a full hip roll. So how are we introducing the planes of movement? We're going to introduce them in this fashion. We start with flexion because it's the most relieving. Thank God for that. Then, of course, we're going to add some rotation, and we should be able to do gentle rotation. We could actually add small range movement first and then add full range, just depending on the pain that the client has. Side bending. So you'll find if the facet joint, for example, is irritated on the left-hand side, I go to a side bend on the left hand, ow, it's going to irritate. So very similar to what we did with the disc. Try not to collapse, think long line and reach so you get a nice stretch in this side but without crushing through the side that's compromised. On the other side, lift up and again, and you'll probably want to stretch the compromised side much more because there probably will be some form of muscle hypertonicity in that area, so it will feel nice to stretch. But again, really try and keep even on both sides because you're trying to get that as best a balance within your imbalance as possible, yeah, within any of these exercises. So hopefully we're okay with that. So facet joint, as I said, out of all, it's probably the most common. At some stage, all of us will have some form of facet joint irritation. What you may find, going back to the disc issue, that the disc itself, because it's layered, so if you cut an onion in half, you have all those layers, that the disc has that as well. It's like annular layers, and in the center there's like a gloopy toothpaste, like the nucleus. And what you'll find with that is you might not necessarily just get a disc prolapse. With injury, maybe an over twisting movement, maybe excess DIY, people might tear one of those layers, an annular tear it's called. It might not necessarily be a disc prolapse. So you may treat it in this fashion, but you may treat it in the disc fashion because it might just be a disc injury. The only thing I would suggest, if that is the case, you just remove rotation temporarily, probably up to a few weeks, yeah, until rotation no longer becomes painful. Okay, going into sacroiliac joint dysfunction. So there should be joint there. Now this is common with a lot of people, and it also depends on how in fashion it is. So for example, when I was through my osteopathy, everything seemed to be an SIJ dysfunction. Then before that, it was very much no discs. Then, of course, after that, it became very much no, everything's a disc injury again. And now there's sort of another fashion on the SIJ dysfunction. So you'll find that there are people out there that are much more knowledgeable in SIJ dysfunction than I am. I'm just giving you the basis. I'm only giving you my opinion and some of the research out there. Okay, so basically I find that SIJ dysfunction is around in these type of people. So when it's really mobile, that tends to be one of the major issues, and that happens with pregnancy, maybe postnatally. Someone could be hypermobile. Your actual client is hypermobile or has things like Ehlers-Danlos syndrome, which more and more people seem to be being diagnosed with EDS. It is a form of hypermobility. Okay, you can also find that people could be hypermobile through that joint because they've got systemic issues like rheumatoid arthritis, like lupus, like Marfan's, like scleroderma, like polymyositis. Now, all of those I'm not going to go into, but again, have a look up on those if your clients have any of those, because there are do's and don'ts to many of those things, and there's things and presentations that happen with those clients that you may need to be aware of. Then, of course, not only have you got a very mobile pelvis, you've got the opposite, which is a hypomobile. So when it's really restricted in its movement. Now, it can be restricted in its movement for a couple of reasons, predominantly age, actually. So as we get older, it becomes a little bit stiffer. And also if there's been osteophytes laid down because they've got osteoarthritis. So this development of osteophytes actually reduces the synovial fluid production as well, or how it can get through, and so you'll find that it becomes very, very stiff. So why does the body produce these osteophytes? Well, these are produced because there's a law called Wolff's law, and it means if there's any line of pull in the body, calcium is laid down. So the classic example of that is if you go to the back of your ears, you'll find these knobbly bits called your mastoid processes. And when you were 3 months old, you wanted to hold your head up. And guess what? They started to develop as you started to try to lift your head up. And once the pull was there, the calcium was laid down, and then the sternocleidomastoid mastoid was able to hold you up or bring you up. So they are there for a reason. So you'll find that osteophytes are put down to protect the body in a way, but what actually has is there's this detrimental effect because there's these additional bone put down, and actually it could irritate the local nerves or create some form of pain because the nociceptors are too excited. So the causes of SIJ are above, but also what you'll find from one of the last papers I just looked at, which is a fairly recent paper, 2018, it started looking at the ligaments. So I always sort of find that there's a lot of ligamentous issue in SIJ. So if you think about how the sacrum is, this sacrum doesn't have it, but there's ligaments at the front and ligaments all at the back, not even just the iliolumbar ligament, but all of the ligaments around here to try and support this network. And those ligaments also then attach into muscles, and then of course there's the sacrotuberous ligament that goes down into the hamstrings as well. That's just whack myself with the skull there. Okay, so basically what you'll find in many of the MRIs is they've got this associated dorsal interosseous ligament, which is trauma. So you can actually find that people have SIJ dysfunction if they fall off horses and things like that as well. So postpartum is still considered a trauma to the body. And of course, what you'll find is there's an associated muscle abdominal weakness. And this is what we need. Forget about all the full detail to it, because we are not clinical people. Well, I am, but I'm saying as a Pilates teacher, I'm not. I'm a Pilates teacher. So all I'm thinking is, I don't really care much about that. What I want to know is, why do I need to know that? So really what I want you to take home from this is that there is potentially abdominal weakness, and that's what we need to look at. So it's always around, or it says it's around that S2 level. Guess what S2 is? That is your center of gravity. So if you look at your posture analysis that you're doing, Is your body going from that center of gravity? And actually the center of gravity is key, as is the eye line. So those 2 points on the body is really clear. Everything is pointing towards the horizon. So if you can get that stable and in line, then have a chance to work through the abdominals and making sure deep abdominals are working efficiently as well as the more superficial, then we've got a fighting chance. What you'll also see is that the disruption leads to a hamstring tightness. Yes. Also, bum gripping is a classic. So bicep femoris, hamstring insertion injuries. Guess what? Oh my God, I have a left SIJ dysfunction. It's been going on for years. But guess what? I also am. I'm a bum gripper because I've been running since I'm 18 and I'm in my 50 now. So I've been running a lot of years. And I just tuck under, my sacrum is counter-nutated as well. I'm all of this. And I've had hamstring insertion injuries because a few years ago I decided to take up handstands and then kicked, and of course wasn't warmed up because I thought I could do that at 47 instead of, now my knowledge 7 years later is a little bit better. I realize I can't, I need to practice. So basically all of those sort of things could lead to this, yeah? So just try and find out a little bit about their history and then look at that. What does that mean to you? How are you going to deal with that? How are you going to do your one leg circles? How are you going to deal with your hip lifts or your shoulder bridges or things like that? Is it going to irritate the hamstring? How can you get out the irritation of the hamstring? So it's not then just about the SIJ, it's all about the surrounding musculature, yeah? So also what you might find is there's a contralateral adductor tightness. So then we're looking back at the sling systems, lateral sling system, yeah? So you also might find that that happens. And if you look in this particular research article, it said 60% of the patients with sacroiliitis, osteophytes they had a weakness in glute med, and of course they had this adductor tightness. So it's all associated. And as I said, this counter-nutation, this posterior tilt of the sacrum as well. It's where the tail or the coccyx goes more towards the front. So you end up with that flatness. And that really strains the iliolumbar ligament. The hamstrings are shortened and it's pulling on that further. So all of this links in. So how is this aggravated? It can really be aggravated by things for a long period of time. So if you're standing still, you're sitting for a long period of time, even your sleep position, if you're side sleeping, you're bringing your knees together and you've got nothing in between your legs, think about by squeezing the knees together, what you're actually doing is you're putting the posterior ligaments of the sacrum on stretch. The anterior ligaments of the SIJ is looser, yeah? So that's, whereas it's the opposite way, think about pushing out something like an abductor machine, for example, what you're actually doing is tightening the anterior ligaments of the sacroiliac joint and loosening off the posterior ligaments. So what's that mean to us in Pilates? Well, if you stick a ball between the knees, guess what you'll be doing? You're tightening up the posterior ligaments. Does it create pain? Yes, it does. Take it out. Put a fitness circle or a circle around the outside of the thighs, push against that. Does that create pain? No. Excellent. Let's do that one. So suddenly, all this thought that you were saying, oh yeah, when I've seen my posture analysis, I've seen a medial rotation at the femur, I'm going to stick a ball between their knees. No, that's probably not the right idea. All you're doing is actually encouraging more of a knock knee. So in fact, you're probably wanting to push something out and keeping the legs in alignment. All right, so just be aware, don't do passive adductor balls between the knee just for the sake of it. Really have a look at the structure of the legs, and this will have a knock-on effect onto your SIJ as well. So you need to change positions regularly. And what you may find, even within your Pilates class, they need to change positions from one to the other as much as they possibly can, yeah? They might not be able to stay in one position for too long. So again, looking at the exercise programming to that. So they're looking at a pain-free range of movement, closed kinetic chain. The only thing I've got a bit of a weird issue with is non-weight bearing. I'm a little bit why. We're weight bearing creatures. We want to be able to walk. The only thing I can think of is if it was too mobile, but even so, I really do question that. Yes, Pilates itself is not particularly weight bearing, but I wouldn't then sell someone not to walk either. So I have a look more into research. It's an area I definitely need to look more into as well. But you are going to address it low, closed kinetic chain initially, which to me is weight bearing. Okay, so maybe impact might not be the initial thing you want to do, but certainly you can introduce that later on. What you might want to do is definitely address the muscular imbalances around the area. And of course, if it's post-pregnancy, you may need to have an SIJ belt, and that's actually a very thin belt that runs around just below the ASIS or around the ASIS to hold the pelvis in position. And you could then start to create that muscular balance while you're working on and off with the belt. Yeah, so I've got some exercise examples here. Some of them are obviously the equipment, like push through on the caddy, footwork on the caddy. Think about the abducted position rather than squeezing everything together. Mat work as well. You may, as I said, need blocks between the thighs, but you may also need circles on the outer thighs. It just depends on what's more comfortable for your client. That's it. It's just, honestly, I'm like that. A lot of my stuff is hit and miss. I sit there and go, does that hurt? No. Okay, then let's do this. So again, it's just about trying to work with the system, trying to work with Pilates, look at your exercise essence and look at what it should look like. It doesn't matter what the books look like, because the books are they are just perfect in their alignment. We don't need to be that perfect, okay? But what we do need to be perfect about is our teaching into alignment. We don't need to have our kick, as in a side kick, up to our nose, but we do need to maintain that spine and predominantly in neutral, so the lever length might be either reduced or it might be a smaller kick, and that is it, okay? So you're working predominantly in neutral only if tolerated. If it's not tolerated, then guess what? You need to work in imprint or whatever is tolerated. Okay, moving on from here. So one of the last conditions I put down is osteoarthritis. Osteoarthritis is really common. So predominantly people over the age of 45 will have some form of osteoarthritis in their body. The most common joints are weight-bearing joints, although the shoulder is common as well, because you can get things like shoulder replacement and people that overwork their shoulders as well. And the thumb, that's another area you can get osteoarthritis, but predominantly it's weight-bearing joints, in particular the hip and knee, because those are the most common joints that actually end up with some form of surgery, like a replacement. Osteoarthritis really is just the wear and tear of the cartilage. It is a destruction of the cartilage. So that just shows you that initially when we looked at that model of joint function, the joint itself is incongruent, and so therefore is creating some form of shearing around that joint, and that would then desiccate the cartilage. So it ends up looking like desiccated coconut, and then eventually bit by bit that reduces the synovial fluid, which then will create even more brittleness through the cartilage, and eventually there'll be bony spurs as well, and then exposed bones. So it's not a nice place to be in. And of course that also creates that, what I said, the formation of osteophytes, Wolff's law. And again, all of this is a cyclical, anyway, it goes in a cycle. So basically, this is what happens then again, if the joint is not particularly in its best position, then the cartilage is dissipated, then guess what happens to the ligaments? The ligaments become looser. And so again, it's becoming very lax and open packed rather than this closed packed joint. And then what happens is the muscles need to take on the role. So the muscles become tense around it because the ligaments can't support it on its own. The cartilage is no longer as thick and juicy as it used to be. So the muscles start to take over and start to create that hypertonicity. So in the back in particular, it could be the similar example that we said before, where one aspect is really in spasm and the other area isn't. It can create nerve irritation, might not. It can create impingement, it might not. It may create pain referral as well, certainly if you're in the lower spine down to the legs, and if into the neck, because osteoarthritis is quite common in the neck as well, into the arms. So there's all these different things that could happen, yeah? So if we're looking at pain referral, just to go back to what I originally said, anything that upper lumbar L2 to L4 is very much femoral obturator nerve, which is anterior thighs, maybe into the groin, adductor area. Anything L4 downwards, so that goes all the way down into the sacrum, what you'll see is very much a pain presentation in the backside, literally the backside, the glutes, the posterior thighs. The saddle area tends to be a bit more sacrum though, I must admit, the shin and the foot. Yeah, so those are the sort of common presentations. They do normally have some form of long-term anti-inflammatory use. The thing with the anti-inflammatories on a long-term basis is actually increases the risk of osteoporosis. So if you're dealing with older people, you also need to think about your osteoporotic guidelines. So although I'm not going to go into too much of these here, but if you look at the nice guidelines, they are there. It what people say is don't flex. Actually, the nice guidelines don't say don't flex. They say your ADLs of flexion is fine. What they want is they don't want is end range flexion. So you'd probably be able to do something where you maybe start a little extension up to flexion if you were doing like an ab prep or something, but actually you don't want to certainly start thinking like half roll back, full roll downs and things like that. So you're looking at that end range, but a small bit of flexion, like they need to simulate that in their ADLs is fine, but actually what you want to do with osteoporosis is very much a weight bearing. So not only Pilates, but weights, squats, all of those sort of things will actually increase the bone mineral density. So if you are not only a Pilates teacher, but you also do some form of personal training, maybe doing a weights program with Pilates is great. Or if you are also trained on the apparatus, start getting them to work the apparatus, because of course there's a resistance there. So you could actually then start to help that person who's osteoarthritic. So again, the exercise programming, pain-free range of movement, neutral or imprint, depending on the client. So again, this is much more vague actually. The key concept is articulation, because actually what would happen if the osteophytes keep growing, actually fuses the spine. So there's a natural fusion. And actually we don't want that. We don't really want the bony growth to grow so much that it actually fuses those spine together, those vertebral bodies together. So try and articulate, make sure it's even articulation through the spine, make sure it's not just in one section. We're wanting a longer warm-up, yeah? So again, there's a good 10, 15, 20 minutes warm-up. Certainly if the weather's cold, maybe encourage them to wear layers if you're in a big class situation and the room's a little bit cool. What you're looking at is planes of movement. So planes of movement is all dependent on the client and how they can tolerate it. Flexion bias normally relieves the pressure of osteophytes on the lumbar spine, but it might not, but it normally does. Articulation like cat stretches, hip rolls, all of those things are really okay. Even half rollback's fine, as long as they're controlled, yeah? As long as there isn't that, oh yeah, they have osteoporosis. But certainly you want to articulate the spine. Side bend and rotation is fine. So you're trying to get the range of movement as much as you possibly can. What you may find though is extension can be a little bit painful. But again, we don't want to stop extension totally. So maybe start in a flex position and then extend to neutral. Yeah, so maybe when you've got, if you're doing the mat, you could do a breaststroke over the art barrel or something similar. So where the lumbar spine is in that flex position to start. You could always do kneeling exercises like chest expansion. So you could do that with a band instead of the equipment, or standing in the same thing. So you could encourage even a band, grabbing a hold of band, and you just literally pull the band to get extension through the chest, or even with a fitness circle. So you could do all of this because we do want to extend the spine, but what we're just having to be mindful of is we don't actually want to make this too painful for them, because we want their trust. And of course, we also would love to give them exercises, homework that they can do in their own time without causing pain. The big thing with osteoarthritis, whatever you're doing, is the 2-hour rule. If they are still aching 2 hours after your session, your exercise session has been too intense for them. And so you need to kick back. And so therefore, some of these things you need to be aware of. Again, going back to AS actually, ankylosing spondylosis, again, if they're aching 2 hours afterwards, and sometimes they do, and certainly some of these AS clients, they'll push themselves, they really need to just step it back a little bit, because it's that inflammation in the spine that's starting to create that. Sometimes I have a client, he's in his 70s, he loves Pilates, he thinks it's amazing, he will sell it to every single person that has AS. But sometimes he pushes himself a little bit too hard, and guess what he does? He irritates that upper lumbar around the L2 point, because he overextends or he over tries to do things, and he shouldn't be doing that. Okay, so just have an awareness. Sometimes your clients are their worst enemies because they want to prove it to you and also prove it to themselves. Okay, so moving on from here. So how do we teach this? So we're literally thinking, oh my God, we've got all these different conditions in one class, and that can happen. You can either encourage them to see you privately just for a little while, even if it's only a few sessions to get them on the straight and narrow. Give them homework. and then of course they will be better in the class situation. Or you do a specific class that caters for back people, then you keep the numbers down, and that way you can keep it at a low level for it, and you're more likely to then be able to concentrate on everyone. At the moment though, as we know, a lot of us are on Zoom. We might not necessarily be doing classes face to face, so we also have this concern that we can't actually physically touch our clients either, and that might be happening even when we go back to teaching, that we can't physically touch people straight away. So therefore we're going to have to be able to be better at our verbal skills. Okay, so this is something we need to consider. So maybe the class sizes need to come down, so consider running those smaller classes for those lower back pain sufferers, then try to move them onto the regular classes when it's possible to do so. Use things like the props that are available, like your bands, like your circles, your balls, your foam rollers, resistance for support, even towels. You know, sometimes when I'm teaching my Zoom classes in their house, I'm looking around their whole environment. What have they got? Have they got posts that we can use to tie bands against? Have they got walls that they can use, so we can use the wall as well as support? So there's lots of things that we could use for support. Make sure your clients have cushions or anything further to support for their head and the likes as well, or even cushions for prone exercises if you haven't got things like art barrels. So there's lots of things you can do, not only in your own teaching environment when your clients are there, but also when they're in their home environment, and whether you're there with your little kit that you bring with you, your little bag, or you're doing it via a Zoom session that you might need to say, hey, can you take that? Hey, can you take that? But it really is about trying to now develop our verbal cueing, and I am so guilty of hands-on correction, and it's really going to be a struggle over this next little while not to be able to do that for a while. Okay, so finally, right, the end of this is just all the mat-based exercises that you're so familiar with. Some of them you could add some bits and pieces to, but I am really not trying to reinvent the wheel here. I'm literally keeping the exercises low load, and then I will eventually progress to the full system. I will put them at the beginning, then slowly work them through the essential or basic repertoire, then into the intermediate, and maybe if we're lucky we end up with a few advanced exercises as well. But we're all working on ourselves all the time in Pilates. So what we have for a warm-up: knee drops and leg slides, tabletop, one leg and then two if tolerated, a spinal rotation with the feet on the ground. So basically you're on your back, feet are on the ground, and you're dropping the knees to one side and the other. Simple spinal rotation. I think in some of the body control people, they may call that a hip roll. We call hip rolls the spine curl, yeah? So the hip rolls or the cat stretch. Scapular isolations, working through the shoulders. You'll think, hang on a minute, I'm working at the stomach here. Yes, we're working the body as a unit, but we're still focusing very much on the abdominal area as well as the back. You'll start to work against maybe the wall, because if you do scapular lifts, scissors and everything against the wall, you can actually feel the stomach muscles engaged, and then transfer that back into them lying on the mat, and they'll get more benefit out of it. Think about your head nods into your ab prep, your reverse head nods that will take you into your breaststroke prep as well. So there's lots of things that you can do in your warm-up. And then, of course, there's all these exercises here. There's loads of them. You can do different things with each of the exercises. I'm not teaching you anything different than what's in the repertoire. So we could do half roll backs with a band if you can do your half roll backs. Make sure there's no compression. Of course, you're avoiding those with disc injuries initially. Modified hundreds, you could do it kneeling. You could do it with the feet down. You could do it with the feet in tabletop. You could do it with a band over the shins, you know, to get the shoulder stability connection. You could do it with straight legs along the mat if their hip flexors aren't gripping. So there's all these sort of things. Your spine twist, you could do it cross-legged, you could do it long-legged, you could do it prayer position, you can take the arms out, you can hold a fitness circle. Again, there's lots and lots of modifications that you can do here. So again, with the side kick, the side kick's an amazing exercise. I think we forget how great this is. The side kick and the side leg series are great. What you could do with the side kick, if they're collapsing underneath, is take that exercise and do it standing. Yeah, standing on maybe a platform, and see how far they can get their leg. By keeping their balance on the one side, of course, they will then see, oh, shouldn't be kicking the leg so far. when I'm lying down, because we're trying to not compromise the spine movement. So a lot of it really is not necessarily what exercise, it's about your teaching. It's about your cues that you can deliver your clients in order to do this. So with this, all I'm doing is the theory here, and then what we're going to do is we're going to switch over to then add this in a practical setting, and I'll show you that on the next clip.